for today's webinar. My name is Anupma Narotra and I'm working as clinical specialist at PIVCer, the leader provider of medical devices. And today we'll be discussing about the topic nurses. So it is about infusing care is our passion. And here with our panelists, we have Lieutenant Colonel Madhumita Dhall ma'am, and who is Director of Nursing there with RGCIRC, New Delhi. We have Dr. Arijit Guha with us, who is GM and Head of Medical Affairs at PIVCer. Today we will be discussing about the IV nurses. We'll be discussing about the IV therapy and what are the complications with IV therapy, how we do assessment for PIVCs, and how do we manage the complications which arises from these peripheral intravenous catheters. And additionally, we'll also be discussing about IV flushing, the importance of IV flushing, and the management of PIVC will include about how they do secure these IV cannulas or center lines as well. And if you have any question during this whole presentation, so we also have a room for Q&A session at the end of the presentation. So in case any query or any question you want to ask, you can always pitch in with the comment box or chat option at the last of this presentation. And now without further delay, I will turn the time around to Madhumita ma'am. So a brief introduction with Madhumita ma'am. So Lieutenant Colonel Madhumita ma'am is Nursing Director at RGCIRC, New Delhi, and she has a total experience of more than 32 years. And she is graduated from AFMC College of Nursing, Pune, and was commissioned in military nursing service. She had served in Indian Army for 23 years for various hospitals in various aspects of operation, teaching, training, and administration. She has worked as administrator in Shri Ram School, Gurugram for 1 year, and she has served in Indian Army for 23 years. Also worked in flagship hospital of Fortis Group FMRI, Gurugram for 4 years, and she is a certified pediatric and intensive care nurse from service. She also holds certification in medical tourism infection control from AHPI and NABH accreditation standards from hospital. And she has also initiated certification courses for in-house nurses. She is an active participant in various conferences, workshops, and webinars, and has conducted nursing conferences at national level and nursing symposiums at international level. So over to you, Madhumita ma'am.
Thank you, Anupama, for such a introduction. Before I start my session, I would like to thank each one of you for giving me this opportunity to present in this webinar. And I would like to, and I would try to do justification to this webinar. So may I start?
Yes, ma'am.
So today's topic is nurses infusing care is our passion. As we all know, nursing involvement in the practice of infusion therapy has become a highly specialized practice. The role of a nurse in infusion therapy has changed a great deal over the past decades. I mean, past decades when nearly more than 30 years. An infusion nurse is a registered nurse who specializes in the administration of medication and fluids through an intravenous line, central line, or venous access port. Infusion nurses, they ensure that the patients receiving infusion therapy receive care that is appropriate for the therapy ordered, from choosing an appropriate infusion device to the management of the device as well as monitoring and evaluating the patient's response to IV therapy. Now, a little bit of history of intravenous therapy. In 1830, Dr. Thomas Latta, he discovered that injecting salty waters into a patient's bloodstream has a measurable impact on fighting cholera, which removes water from the bloodstream. In 1834, Dr. James Blundell, he used blood transfusions on postpartum hemorrhages. And in 1930, for the first time, a glass vacuum seal bottle was used for intravenous therapy. Now, what is intravenous therapy? It is the treatment that infuses intravenous solutions, any medications, blood and blood products directly into a vein. Now, the word intravenous, it simply means within a vein. Now, we would like to know few indications of intravenous therapy. What are the indications? The first is to replace fluids and electrolytes and to maintain balance. Then to administer medications, including chemotherapeutic drugs, anesthesia drugs, and diagnostic reagents. Then about 40% of all antibiotics are given intravenously. To administer blood or blood products, and to deliver nutrients and nutritional supplements like TPN. Coming to venous access, safe and reliable venous access for infusions is a critical component of patient care in the acute and community health setting. So there are a variety of options available. A venous access device must be selected based on, there are few criteria which is required to select why you want to give venous, why you want to do venous access. That is, number one is needs of the patient. First of all, you have to identify what is the need of the patient. Then the duration of IV therapy. That means for how long the therapy will continue. Then types of medication. What type of medication you are going to use for during this therapy. And the types of solution that to be infused through venous access. Now, the types of venous access, primarily there are two types of venous access. One is peripheral and the second is central venous catheters. Now, there are various central venous catheters. One is your percutaneous central venous catheter, that is your central line. Then peripherally inserted central catheter, which is we commonly call as PICC line. Then subcutaneous or tunnel central venous catheter, that is your Hickman catheter. And implanted central venous catheter, that is your port. Today we'll be basically discussing, we will put our emphasis on peripheral intravenous catheter, that is PIVC. A peripheral intravenous catheter is a common preferred method for short-term IV therapy in the hospital setting. It is a technique in which a cannula is placed inside a vein to provide venous access. Now, venous access allows sampling of blood, administration of fluids, administration of various medications, parenteral nutrition, chemotherapeutic drug infusion, and transfusion of blood products. Coming to the assessment of PIVC, first we should know what is the significance of assessment, why we want to do assessment. First, to confirm the accurate delivery of the drug. That means you want to confirm that yes, you are giving the right drug, you are transfusing or infusing the right drug. Then to know the patient's response to the therapy. If you do not do the assessment, then you will not come to know patient's response to the therapy. Patient response to the therapy, I mean, you have to find out whether the patient is having any complications, or if the patient is well with the therapy, or if the patient, how is the patient respond, whether the patient is comfortable or not with the therapy. Then to detect imminent complications. These complications I will discuss in the later phase of the presentation. Now, when to assess? You have to assess at the time of insertion. That means when you are cannulating a patient, that time you have to assess. Then assessment has to be done at every shift change. This is mandatory. Every shift change you have to assess the cannula. Why? Because then you will be able to identify any complications. And in continuous use of infusion, preferably second hourly assessment to be done, or as and when required, you can do the assessment of the patient and the PIVC. Now, why do you think cannula is required? Is IV cannula needed? So when you have to go to the patient or to the patient bedside for doing assessment of the PIVC, you have to keep few things in your mind. Number one is, what is the requirement for the cannula? Then you have to see whether the cannula is working or not. That means the patency of the cannula. Then tolerated by the patient. Is the patient comfortable after cannulation? Is the patient comfortable during the process of infusion? That is very much required. Then appropriately dressed and secured. Is the cannula that you have put is properly secured? Is the dressing is intact? So that has to be assessed. Then any signs of infection and any signs of other complications. So when you are going, these points you have to remember when you are doing an assessment of PIVC. Now coming to the assessment of the insertion site. So what all things you will assess at the point of insertion site? Number one, catheter position. So you will see whether the catheter is in position or not. Then is the patency of the catheter. Then you will see whether any occlusion is present or not. Then limb symmetry. Here limb symmetry means you have to compare both the limbs and see whether they are symmetrical or not. Then you should be able to identify the signs of phlebitis. Then any signs of infiltration or extravasation. Any leakage from the insertion site. Not only leakage from the insertion site, you have to see whether any leakage present from the connector side also or not. Then PIVC site should be checked every second hourly or as and when required, as per the condition of the patient. Next is the assessment of dressing and splints. Now, when you have to do the assessment of dressing, you have to see the type of dressing that you have used for securing the PIVC. Then the date and time of insertion. So it is very important to mention the date and time of insertion after you secure the cannula. Then check the securement of dressing. In what you will see whether the dressing is intact or not. Then whether the dressing is clean and dry, or is it loose? Is there any visible ooze present underneath the dressing or around the sides of the dressing? Then check the splint. If splint is used for securement of the PIVC, then you have to check the tightness of splint, and you have to even see that whether it is causing any hindrance or in the there is any restriction in the venous flow or not. Coming to the assessment of lines, equipment and infusion, You will again observe the IV site, as I said. Then you will see the patency of the life of the IV line, whether your IV line is functioning properly or not. You will see whether any air bubbles are present or not in the line. Then the type of fluid and volume infused. That means you have to do the assessment that whether you are giving the correct type of fluid and the correct volume which has been ordered to be infused. That has to be assessed. Then you have to also assess the accurate rate of infusion. Then the working condition of the equipment. If the infusion is through syringe pump or infusion pump, so you have to see the working condition of the pump, and you also have to see the pressure alarms. If repeated pressure alarms is happening, then you have to check the complete system from the point, from the cannula point till end. You have to recheck the complete system why repeated pressure alarms are happening, whether any occlusion is there or not. If a patient is on continuous infusion, then ideally 2-hourly assessment is required, or you can do the assessment as advised, or depends on the condition of the patient once again. If the patient is having intermittent infusion, ideally 8-hourly assessment, minimum 8-hourly assessment is required. Again, it will depend on the patient's condition. You can do the assessment. Then for unstable patients who have signs and symptoms of complications, frequent assessment to be carried out. If the patient does not require any more infusion, then the IV access has to be removed at the earliest to avoid any type of complications, especially to prevent infection. Now coming to the management of PIVC. First, I will discuss about the administration of bolus or loading dose. Now, what do you understand by bolus or loading dose? It is an IV push, or bolus is a rapid injection of medication. That means a rapid infusion of a certain amount of drug is introduced into the vein. So for this, a syringe is usually used and is inserted into the catheter to quickly send one-time dose of drug into the bloodstream. Now, what are the precautions, or what are the extra precautions you will maintain when you are doing administration of bolus or loading dose? That is, first is you have to maintain the 10 rights of medication. Please remember the 10 rights of medication. So in this, you have to identify the medication to start as per the order. Go through the doctor's order very carefully. After reading the doctor's order carefully and rechecking the doctor's order, then you start the medication. Then review the administration guidelines. Some particular medications may have particular guidelines, manufacturer guidelines. So read through those guidelines and then do the administration for the bolus dose. Then prepare all the articles required for injection. Then prepare the medication as per the guidelines, as I said. Then before you administer the bolus dose, you have to clean the injection port or the injection site with 70% isopropyl alcohol swab. That is, you have to follow the scrub the hub. That is 15 seconds rub and 15 seconds to air dry. After doing this only, you will administer the injection. This is done to prevent blood infection into the bloodstream. Then flush the PIVC before administration of the drug with sterile 0.9% sodium chloride. Then you administer the bolus or the loading medication as advised, and again reflush the catheter post administration to maintain the patency of the line. Now coming to the continuous infusion of IV fluid. Is the infusion of IV fluid medicine over several hours to? What do you mean by continuous infusion? It is the infusion of fluid or any medicine over several hours to days. So what are the management? You should replace continuous administration set. Here administration set means your infusion set, IV sets, used to administer solution other than lipid, blood or blood products, no more frequently than 96 hours. So as per the CDC guideline, if a patient is on continuous administration, you are not supposed to discontinue the administration. You are not supposed to discontinue the administration set, and after 96 hours, you will change the administration set unless otherwise indicated. If it got infected due to any reason, then you have to change the infusion set. Then avoid disconnecting continuous administration set from access site. As I said, double check each bag of fluid to be infused. Before you infuse, you have to double check the type of fluid you are infusing as per the order. Then you have to put infusion label with date and time on the bag. Then you have to check the rate and amount to be infused. Then you have to check the solution. As I said, prescribed solution you have to check. You have to again check the prescribed rate of infusion, which has been mentioned in the doctor's order, and the total amount of infusion that has to be given. That has to be also double checked. Then you have to document the infused volume on the fluid balance flow sheet. Fluid balance flow sheet means intake output chart. Then you have to check the infusion site for any complications. If you find any complications, then you have to document that assessment, what the findings, what you have found in the assessment, that has to be documented clearly in the notes. You can even document your findings in the fluid balance flow sheet also. Then review cumulative volume infused and fluid output. This is very much important in cases of cardiac patients, in cases of renal patients, because when a patient is on continuous infusion, fluid infusion, cumulative volume you have to assess, and you have to strictly monitor the output of the patient. And also cumulative volume infused and fluid output also will depend on the patient's clinical condition also. So this cumulative volume review can be done 2 hourly, or it can be done 4 hourly, depending on the patient's clinical condition. Now coming to flushing of PIVCs. Now what is flushing? Flushing of an IV catheter is defined as a manual injection of 0.9% sodium chloride or so-called normal saline in order to clean the catheter, to maintain the patency of the catheter, and to prevent any complications. Now, why flushing is important? Flushing, when performed correctly, represents a key procedure in maintaining the patency by preventing occlusions. Then it minimizes the potential for the adherence of harmful microorganisms that can lead to biofilm formation and catheter-related bloodstream infection. Then it also reduces the chances of drug-to-drug interaction in the catheter, especially when 2 different types of drugs are to be given through infusion. Then it aids in reduction of complications associated with PIVCs. And if we maintain all these things, then it helps to increase the lifespan of catheter. That means the patency of the catheter is maintained, and also the lifespan of the catheter can be maintained. Now, flushing of PIVCs. PIVC should be flushed prior to infusion to check the patency and working condition of the line. That means before you start any infusion, before you give any medication through infusion, you have to do flushing of the PIVCs to ensure the patency and the working condition of the line. Use sterile 0.9% sodium chloride to flush a catheter. Preferably use 10 ml syringe for flushing to avoid excessive pressure and catheter rupture. A minimum of 3 ml to 5 ml normal saline flush is recommended. If any resistance is met, do not forcefully try to flush the catheter. Because if you try to forcefully flush the catheter, you may dislodge any occlusion or any embolism. Use aseptic techniques, including cleaning the access port. As I said, scrub the hub prior to flushing. Then the method of flushing is a pulsatile motion, that is pulse flushing or push and pause flushing. Then when you should flush the catheters, that is when you are cannulating a patient, immediately after putting the cannula, you should flush to maintain and to prevent any blockage due to blood clotting. Then if any sample has to be taken, for example, you have cannulated the patient and you have to take blood sample. So immediately after taking blood sample, you should flush the cannula. Then prior to and after fluid infusion or any injection, then prior to and after any blood transfusions. As I said, in between two different injections, so you have to flush the catheters. Please remember, you should never use sterile water for flushing any type of catheter. Now coming to changing of PIVC dressing. Dressings to PIVC sites are the first line of defense against infection and dislodgements. The dressing must be kept secure, clean, dry, and intact. This is very important. Carefully remove the old dressing. So when you are removing the old dressing, you should hold the cannula in place at all the times. Why you want to hold the cannula? To prevent dislodgement of the cannula. Thoroughly inspect the site of entry of the cannula for any sign of infection, skin injury, or presence of edema. Then clean the area around the catheter insertion site, including under the hub, using a circular pattern with 2% of chlorhexidine, ensuring entire area is covered. See, when we do the cleaning around the catheter, we usually concentrate only on the insertion site. We usually overlook the underneath of the cannula also. So when you are cleaning, please ensure that you clean the entire area, that is at the site and also under the hub area. Allow skin preparation to air dry prior to applying any new dressing. This allows the disinfectant to work. Then cover the cannula insertion site with sterile, transparent, semi-permeable occlusive dressing. Preferably, the dressing material should be a sterile, transparent, semi-permeable occlusive dressing. Why? Because if you have a transparent, semi-permeable occlusive dressing, it will be very easy to assess the tip of the site for any signs of infection. And when you are applying the transparent dressing, you have to maintain aseptic non-touch technique over the catheter to prevent any infection. Change transparent semi-permeable dressing at every 5 to 7 days. Ideally, transparent semi-permeable dressings, these dressings to be changed every 5 to 7 days. Unless you find any signs of infection or the dressing is soiled due to any reason, or the dressing has loosened up, or the dressing has got wet. Then only you will change. Otherwise, you will change the dressing only after 5 to 7 days. Now coming to the securement of PIVC. Please remember, securement of PIVC is very important. Secure dressing prevents loosening and catheter dislodgement. Secure PIVC using as I said, you have to secure PIVC using semi-permeable transparent occlusive dressings. For example, Tegaderm, which allows continuous observation of the site and also helps to stabilize and secure the catheter. If you are using splints, then you can use splints to secure PIVC if the PIVC is placed in or adjacent to the areas of flexion. Areas of flexion means at the point at the joints, any joints. Due to any reason, if you have to put a cannula, then you have to secure it with splint also. Now, change of PIVC dressing and securement. To summarize, when dressing a peripheral IV cannula, you ensure that it is secured properly, the site is visible, the patient can't injure themselves or be injured by the connections. That means what I am trying to say is, like when you are putting cleft connectors or you are putting extension, so that time you have to secure the extensions also properly. First of all, if you secure the extension properly, it will not dislodge the catheter, number one, and also it will not cause any injury to the patient. And third, most important is, it will, if your extension is hanging, then there will be chances of getting in contamination, which will lead into bloodstream infection. Tapes, and when you are using splints, then you have to ensure that the tapes which you have applied on these splints are not too tight or not causing any restrictive movement, not causing any restrictions in the venous flow. Now, change of extension sets. When would you prefer to change extension sets? Extension sets are to be changed when the access device is changed, or immediately upon suspected contamination, or when any break in the integrity. That means whenever you are changing the cannula, your extension sets has to be changed, number one. Or while giving any medication or while transfusing, if you feel that your extension set has been contaminated, you will immediately change. Or if you find any leakage through the extension set, then again you will change the extension set. Extension sets are to be primed and attached to the cannula at the time of IV insertion using an aseptic non-touch technique. When exiting the flushing of extension set, you must use a positive pressure clamping technique. That means when you are flushing the line, and when you are flushing through the extension set, so while flushing, you will clamp the extension set and then you will remove the syringe. This will help in maintaining the positive pressure in the line. When not in use, extension sets must be clamped. Please ensure that when your extension sets are not in use, your extension sets are clamped properly. Now, what are the complications of intravenous therapy? To ensure patient safety, healthcare professional is competent to recognize the signs and symptoms of PIVC related complications during insertion, management, and removal. Please remember, complications of intravenous therapy can be due to insertion, can be due to the process of infusion at the time of infusion, or due in the process of management, and at the time of removal also. So let us discuss what are the few common types of complications that we can encounter on intravenous therapy. The most common type of complication which is usually seen in peripheral intravenous therapy is phlebitis. Then next is your infiltration. You can find extravasation also, infection, air embolism, and hypersensitivity. Now coming to phlebitis. What is phlebitis? It is the inflammation of a vein. Now, phlebitis is usually associated with acidic or any alkaline solutions or solutions that have high osmolarity. So when we are infusing these type of solutions, we have to be very careful while administering or while infusing these solutions. Phlebitis can also occur as a result of vein trauma during insertion, use of an inappropriate IV catheter size for the vein, or prolonged use of same catheter. So these are the very few reasons of causing phlebitis. What are the signs and symptoms? The signs and symptoms are redness at the type of, that will be the first sign and symptom, will be redness at the tip site of the catheter or along the path of the vein. Then when you touch, the patient will have tenderness. Then there will be swelling over the vein area. Even when you put your hand, you will feel warmth at and around the insertion site. So these are the few important signs and symptoms of phlebitis. Prevention. Use proper venipuncture technique, maintaining asepsis. Use a trusted drug reference or consult with the pharmacist for instruction on drug dilution when necessary. As and when required, you should follow the instructions correctly, especially drug dilution instructions when you are infusing drugs which can cause phlebitis. Then monitor administration rate and inspect the site frequently. Change the infusion site as and when required. Now this is your VIP score, visual infusion phlebitis score, which is very important to identify phlebitis. This VIP scoring should be carried out at every shift by the nurse. If you judiciously do this VIP scoring, you will be able to identify phlebitis at the earliest and necessary corrective action can be taken and complications can be prevented. So what does this VIP score includes? The score, VIP scoring is from 0 to 5. So if you find, when you are doing the assessment of the site, if you find the IV site is healthy, so that means there is no sign of phlebitis. So the scoring is 0. Now, if one of the following sign and symptom is evident, that is, if there is slight pain near the IV site or slight redness is present near the site, then it indicates initial signs of phlebitis. So you will give a score of 1 and you will observe the cannula. That means frequent assessment is required. Coming to the next, that is, if two of the following signs and symptoms are present, like pain near the IV site, or erythema is present, or swelling, out of these three, if any two is present, then the scoring will come 2. This will again give you an early stage of phlebitis. You have to think of resiting the cannula. Then coming to, if there is pain along the path of cannula, or erythema and induration, all these three things are present, then your scoring becomes 3. Then you will put it as medium stage of phlebitis, where again resite of cannula is, you have to think. That means you have to change the cannula site and treatment to be considered as per the doctor's order. If pain along with the path of cannula is present, erythema is also there, induration is there, and you have palpable venous cord, that means your VIP score is 4. It indicates that it is an advanced stage of phlebitis. And yes, you strictly have to consider treatment and cannula site has to be changed. Now, coming to the last scoring, that is, there is pain along the path of cannula, there is erythema, there is induration, there is palpable venous cord, and along with that, patient is having fever. That means this is an advanced stage of thrombophlebitis where treatment has to be initiated and cannula has to be changed and the scoring will be 5. So please try to understand when you are doing a VIP scoring, and if you find the VIP score is 2 and above, that means it indicates improper assessment of the VIP score and failure of assessment in identifying phlebitis. So please sincerely do VIP scoring whenever a patient is having infusion in each and every shift. If you sincerely do VIP scoring and if you do proper documentations, we can prevent many complications. Now coming to the management of phlebitis, if phlebitis is present, you have to determine the possible etiology of the phlebitis. You have to rule out what was the reason of phlebitis. Was it a chemical phlebitis? Was it a mechanical phlebitis? Or it is a bacterial phlebitis? Or it is post-infusion phlebitis? So whatever may be the reason, you have to stop the infusion at the first sign of redness or pain. Now coming to chemical phlebitis, if the phlebitis is chemical phlebitis, then you will evaluate the infusion therapy. You have to evaluate the drugs, the type of medication you have been giving through infusion. You have to check for the need of different vascular access. You may require to slow the rate of infusion. You may need to change the drug dilution, and you may determine, or if required, you have to remove the catheter. Now, in mechanical phlebitis, you have to ensure that your catheter is secured properly, is stabilized properly. That means there is no dislodgement or it is not loose. So in mechanical phlebitis, you have to stabilize the catheter, you have to apply heat, you have to elevate the limb of the patient, and you have to monitor the site for 24 to 48 hours to see any further progress. in swelling. If any sign and symptom persists after 48 hours, then you should consider in removing the catheter. Now, other management includes analgesics or anti-inflammatory drugs, which can be given for pain or swelling as prescribed by the doctor. Even topical gels or ointments can be used for treating a phlebitis. Now, coming to infiltration. What is infiltration? Infiltration occurs when IV fluid or medication leaks into the surrounding tissue. So it can be caused by improper placement or dislodgement of the catheter, or infiltration can even happen if patient is moving hand while sleeping, or improper method, or the patient has not kept the have not maintained the position properly. Now, the signs and symptoms include swelling, discomfort, burning sensation or tightness, cool skin and blanching, and decreased or stopped flow rate. Prevention is you have to select appropriate IV site, avoiding areas of flexion. That means when you are cannulizing, avoid joints until unless you do not, if you do not have any other sites, then you use joints. Otherwise, please avoid joints. Use proper venipuncture technique, maintaining all aseptic techniques, proper securing of IV catheter. Observe the site frequently. Advise the patient to report any swelling or tenderness at the IV site. Coming to the management, the moment you see infiltration, you should stop the infusion immediately and you remove the device. Elevate the limb. Use warm compression can be applied depending on the type of infiltration, extent of infiltration. Check the patient's pulse and capillary refill time. Perform venipuncture in a different location and restart the infusion. Observe the site frequently, and documentation is very much required. Document whatever findings is there, and whatever interventions you have performed, it has to be documented. Coming to extravasation. What is extravasation? It is the leakage of the vesicant drugs into the surrounding tissue. Extravasation can cause severe local tissue damage, possibly leading to delayed healing, infection, tissue necrosis, disfigurement, loss of function, and even amputation can take place. Signs and symptoms of extravasation includes blanching, burning sensation, discomfort at the IV site. When you touch the skin may feel cool or warm around the IV site. There may be presence of swelling, and there can be formation of blisters, or even skin sloughing can be present. Prevention is you should avoid small and fragile veins. You should avoid areas of flexion. You should avoid extremities with pre-existing edema, and you should avoid areas with known neurologic impairment. Please be careful while administering vesicant medications such as antineoplastic drugs like doxorubicin, vinblastine, vincristine. They are all vesicant drugs. Then hydroxyzine, promethazine, digoxin, dopamine. When you are transfusing these medications, when you are administering these medications, you have to monitor very frequently. Then when you are transfusing high concentrated electrolytes, 3% normal saline, KCl, magnesium sulfate, then you have to also take adequate measures and proper assessment to be done. Strictly adhere to proper administration techniques. Timely assessment has to be carried out and monitoring to be maintained. Now coming to the management, you have, the moment you see an extravasation, you should stop and disconnect the infusion. Then you should try to aspirate the residual medication from the PIVC as much as possible without causing much pressure. Then consider antidote as order. If antidote is not to be administered, then you remove the IV line. When you are handling extravasation, please use PP. Estimate the amount of extravasated solution that you have withdrawn, and also how much of extravasated and approximate amount of extravasated solution you should be able to write, and you have to notify the treating team. Elevate the extremity, perform frequent assessments for sensation, for motor functioning and circulation of the affected extremity. You have to mark the extravasation site. This is very important. Please mark the extravasation site, because when you mark the extravasation site, you will be able to assess whether it is healing, or it is expanding, or it is deteriorating. Document patient's symptoms, estimated amount of extravasated solution, and the treatment given. These all things have to be documented. Then, depending as per the manufacturer's instructions, whatever medications you have given which has caused extravasation, so depending on that, you have to apply cold or hot pack to the affected area. Now coming to infection. Infection can be local or systemic infection, which is again one of the important potential complication of IV therapy. Now the signs and symptoms of infection, there will be presence of redness, there will be pain at the site, there can be presence of discharge at the IV site, and patient may have fever. Prevention is what? Perform hand hygiene. Before you do any procedures, strictly hand hygiene has to be performed. Don gloves and use aseptic techniques during cannulation. Clean the site with 2% chlorhexidine before inserting the catheter. Ensure careful hand hygiene before any contact with the infusion system or patient. Clean the injection site or the cannula port before each use. That is, you have to remember the scrub the hub policy. Dressing changes and changing of the solution and administration set as and when required. Coming to the management, if you see an infection is there, stop the infusion, inform the treating team, remove the device, send pus swab culture, administer medications as prescribed, monitor the patient's vital signs. With careful attention and skill, you will be able to recognize, prevent, and manage these complications related to peripheral IV therapy. Coming to air embolism. Air embolism occurs when a gas bubble enters a vein or artery. It can block the passage of blood, and the location of the blockage determines the severity and can be life-threatening. Please remember, air embolism can be life-threatening for a patient. So what are the signs and symptoms? There can be hypotension, sudden onset of dyspnea, continued coughing, shortness of breath. Patient may complain of chest pain. There can be sudden loss of consciousness. There can be cessation of breathing. There can be vertigo, and even there can be altered mental status. So when you are administering, please, or when you are before you administer infusion, administration sets and extension tubings to be primed properly before you connect to PIVC. You should ensure that there is no air bubble in the complete system. Careful flushing and drug administration to be done to prevent any air embolism. What is the management? It is an emergency. So immediately you have to take necessary action and you have to immediately inform the critical team, and you have to prevent more air from entering the blood. So what you can do, you will stop the infusion, you can close the, and you can clamp the line. You place the patient on the left side in Trendelenburg position or in the left lateral position. As I said, you have to alert emergency team, start oxygen therapy, and after stabilizing, shift the patient, transfer the patient to ICU for further management. Now coming to hypersensitivity. Hypersensitivity reactions are an overreaction of the immune system to an antigen which would not normally trigger an immune response. So when there is an hypersensitivity, an immediate severe hypersensitivity reaction can be life-threatening. So prompt recognition has to be there and treatment has to be initiated immediately. What are the signs and symptoms? Patient can have rash or urticaria. There can be sudden fever. Patient can complain of itching. There can be swelling. Patient may have shortness of breath. There can be bronchospasm. Patient may have wheezing. You have to ask the patient about, so how we can prevent hypersensitivity. So before we start infusion, we have to ask patient about any history of allergy to any medicine, to any food, and also if any family history is there or not. For infants younger than 3 months, you have to ask the mother about any allergy history because maternal antibodies may still be present in the infant. Then stay with the patient for a few minutes to detect early signs and symptoms of hypersensitivity. Management includes that you have to immediately discontinue the infusion and you have to notify the doctor, administer medications as ordered, monitor the patient's vital signs and provide emotional support. Further management depends on the patient's clinical presentation. For example, if a patient is having breathing difficulty, then you will prop up the position of the patient and you will start oxygen therapy. So before I conclude, I would like to say safety is the engine and you are the key that starts it. Here you means the nurses. Nurses are the key that always ensures patient's safety. Thank you.
Thank you, ma'am, for such an informative session. We get to know about the therapy, then we get to know about the assessment, how we need to assess for the patient. And while nurses are changing shifts also, that time also it is very essential for a nurse to take charge and go and look for the IV lines, whether they are patent, yes or no. And this assessment will ultimately lead to prevention of whatever complication may arise. Plus, very nicely, you also completed with the management part if any complication arises. And we are looking forward for the question and answer section. So, there was one question from the audience, like how significant is it to follow the sterile procedures while vascular access devices. What take home message from this question I can get is like, how significant is it to follow sterile precautions while a nurse is dealing with vascular access devices?
when you are when you are accessing the vascular, any type of vascular devices, please remember it is a direct contact with the bloodstream. So strict aseptic technique has to be maintained. You cannot do any breach in aseptic technique, because if you do a breach, it will be a direct infection flowing into the bloodstream, which will cause CRBSI. So
Truly
strict
mentioned.
aseptic technique has to be maintained for any type of cannulation.
Yes, ma'am. Thank you. And then comes the next question, like how it is important to use pre-filled syringes while dealing with chemotherapy drugs.
We prefer pre-filled syringes. Why? Because see, in cancer patients, the immunity is otherwise also low. Patients have high risk of chances of getting infection. So these pre-filled syringes are sterile pre-filled solutions. So if you use sterile pre-filled solution, this will prevent again chances of infection. So pre-filled syringes to be used. We should not use any type of saline from directly taking from bottle, because chances of infection will be there. Contamination chances will be there. In
Yes,
this
ma'am.
pre-filled syringe, there is less chances of contamination, no chances of contamination actually.
Yes, ma'am. Because the traditional method is to withdraw fluid, like withdraw the saline from the particular NS bottle, and this contaminated fluid will ultimately cause infection to the patient to whom it is being delivered afterwards. Thank you, ma'am. Then the next question is like, when flushing any peripheral lines, is it a good option to use heparin or saline? While it comes to flushing, what is a good option? We should use heparin or saline should be used?
See, for flushing, you should be always saline to be used. You will never use a heparin.
Yes,
Yeah.
ma'am. Thank you, ma'am. Then the last question is like, how to manage extravasated vein in infusion therapy?
I have already discussed
Yes,
how you
ma'am.
should do the management of an extravasation.
Got it, ma'am. So, ma'am, there is one question from my side, like from your nursing experience, like how can we advance with the best practices with IV therapy? When it comes to IV therapy, like how we can enhance the best practices there with IV therapy?
See, the best practices in IV therapy is that see, the nurses should, should have the knowledge of the advanced technologies that are coming, right? We should
Yes,
follow the closed system whenever any infusion is there, and evidence-based practices always to be followed.
yes, ma'am. Got it. Thank you, ma'am, for covering the whole topic. And now I'll be handing over to Dr. Arijit Guha.
Thank you, Anupama. Thank you so very much, ma'am, for covering this topic. I mean, this is a very, very comprehensive topic, and I was amazed that this was covered within just over 1 hour. And the only one word that was coming is that this was a masterclass on infusion therapy. And fortunately, we have had this session recorded, and those participants who missed out on today's lecture will be sort of be able to share them over social media platforms and upon request also. So once again, thank you very much, ma'am, for covering various aspects. I mean, so the audience would by now would have realized that there are so many parts of the entire infusion process, and if any one of them can go wrong, it can, um, um, distort the results that we are trying to achieve. So thank you so very much once again, and thank you to all the audience for taking out time and taking out time for this session. And we hope that it was equally important for you, and you got a chance to interact with the speaker as well. Thank you, Team Polymed, Anupama, Deep, Kuldeep, all of you for bringing in this, session, and so that it benefits everyone, and it benefits the patient, it benefits the practice. So with that, I would um, call it a day for the session. So we can wrap it up for now. And to everyone, have a nice afternoon. And once again, big thanks to Madhumita ma'am.
Thank you, Dr. Arijit. Thank you, Anupama, and thank you the entire team for giving me this opportunity. Thank you, audience, for listening. Patience.
We got we got a comment also, like it was very informative and refreshing session for all of them, ma'am. Thank you so much.
Thank you. Thank you.
Yes,
You're
ma'am.
welcome.